Good morning, everyone. My name is Dr. Val Montessori, and I'm the Director of Clinical Education at the BC Centre for Excellence in HIV/AIDS. Welcome to the BC Centre for Excellence Anniversary Conversation Series. This year marks 30 years since creation of the BC Centre for Excellence, and the aim of these events is to celebrate and commemorate the journey and the accomplishments of the community, advocates, researchers, and healthcare providers that have worked to turn the tide of HIV in British Columbia. Today's session is titled The Early Days of Treating HIV in BC, covering the initial appearance of HIV in BC until the advent of highly active antiretroviral therapy in 1996. Dr. Peter Phillips is a clinical professor in the Division of Infectious Diseases at the University of British Columbia. Following Dr. Phillips' presentation, I'll be joining Dr. Phillips for a conversation about our experiences of treating HIV during this time and moderating questions from our audience. I'm the head of the Division of Infectious Diseases now at St. Paul's Hospital, a position previously held by Dr. Phillips, and I'm the Director of Clinical Education, as you know, for the BC Centre for Excellence. I'm also a Clinical Associate Professor of Medicine in the division and Associate Medical Director of the John Rudy Immunodeficiency Clinic, and I'm really pleased to be here today. Before we start, I'd like to acknowledge with gratitude that our place of work is on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh. If you're listening to the webinar by phone, or if you have additional questions after the webinar, please email your questions to education@bccfe.ca. And following the webinar, you will also receive an evaluation link for this event, and we encourage you to complete that because it really helps us improve our programming, and we love to hear your opinion. This webinar is being recorded, so the video of the presentation will be made available on the BC-CfE website. Before we start, I do want to acknowledge our BC-CfE communications team, the clinical education and training team, and the IT team. This program has not received any financial funding or in-kind support, and the content of the presentation has been developed by Dr. Phillips, our presenter. Okay, I think we're going to switch spots now, and I'll leave Dr. Phillips to begin the presentation.
Thanks very much for the introduction, Val. My objectives are first to review a number of the key timelines in regard to the HIV/AIDS pandemic, and then provide a description of the spectrum of illness in terms of symptoms, signs that the patients experienced, and also touch on psychosocial factors and the experiences of healthcare providers in that environment. Just for any in the audience who are not with a medical background, this slide is just to clarify that HIV infection is what is initially present for typically a few years prior to the progressive deterioration in the immune system as a result of HIV viral depletion of CD4 lymphocytes, which are critically important cells of one's cellular immune system. And over time, as the immunity declines, then individuals who are infected become predisposed and at risk of developing opportunistic infections that would otherwise be very unlikely in most instances to develop, or opportunistic cancers that may occur in the general population but are at much higher frequency among individuals who have advanced HIV disease. So this slide summarizes a number of the key timelines during the interval from 1981 to, well, just beyond 1996, which is the time period that we've designated as the early days that reflect the HIV era prior to the introduction of highly effective antiretroviral therapy. And it started off in 1981 in June with the first signals of a disease showing up initially in Los Angeles and also in New York. The following year, the CDC in Atlanta had developed the name acquired immunodeficiency syndrome. Prior to that, it had gone by a number of other names. And then the following year, the CDC also made an announcement with respect to clarification of the means of transmission, which was typically by sexual contact, blood transfusion, sharing needles with injection drug use, that sort of thing, but not by casual contact, airborne, or water, or food, or from environmental surfaces. And that was an important landmark in terms of information that had been gained with respect to this new infection, although at that time it wasn't even proven yet that it was of a viral cause, which was established and confirmed the following year in 1984 based on research done in both the US and France. However, it's been many years before that CDC announcement in 1983 with respect to transmission became generally common knowledge in the community, and it is still something that is an obstacle for some individuals in terms of lack of awareness and concern that it may be transmitted more easily, but in fact there's no evidence to that effect. In 1985 there was the first commercial HIV test which was developed, and in 1987 the first antiretroviral antimicrobial agent in the way of zidovudine or AZT was released and was entered into clinical trials. By 1994, AIDS was the leading cause of death in both men and women between age 25 and 44. And then in 1995, two important additions to antiretroviral therapy came in the way of protease inhibitor and also non-nucleoside reverse transcriptase inhibitor. So there were now three classes of drugs available. And in 1997, in large part based on the activism of groups like ACT UP, there was the Modernization Act passed with respect to accelerating drug approval process, which had a light shone on it by groups such as ACT UP, and was evident that there were numerous obstacles and delays that were unnecessary. So this slide shows the death rate annually worldwide in those, well, up to 2019. Does not go any earlier than 1990, but you can see that the death rate peaked globally in 2005, a total of 36 million estimated HIV deaths over this time period to 2019. And similar graph for Canada shows a much different time course, with a peak of deaths occurring about 10 years earlier in 1995, where there were just over 1,600 deaths across the country. And like many other countries that had relatively early access to triple drug antiretroviral therapy, the mortality was abruptly reduced soon after the introduction, in contrast to other countries where it became available much later. So the early signals coming out in June and July of 1981, first was the report of Pneumocystis pneumonia in Los Angeles, which is an infection that occurs rarely in people with reduced immunity, but is something that would not be expected in an otherwise healthy individual. And around the same time, these rare cancers were showing up in gay men, known as Kaposi's sarcoma. Again, something that might occur rarely, but this was certainly out of the ordinary. The various sites affected are basically almost every portion of one's body, any organ. It's a head-to-toe type of disease. And these are just some examples of opportunistic infections or cancers that can be encountered. Fungal meningitis, parasitic brain abscess with toxoplasmosis, HIV dementia, and so on. Cytomegalovirus was the main cause of visual damage, and lung infections, particularly pneumocystis, and also bacterial pneumonias, and then intestinal infections, both parasitic, microbacterial, and others, which resulted in a variety of disabilities and discomfort and pain and suffering that ranged from problematic to devastating. And the three main opportunistic cancers, I mentioned Kaposi's sarcoma, but also a type of lymphoma, non-Hodgkin's lymphoma, which was often fatal, and also cervical cancer, although not uncommon in the general population, at much greater risk among those with low CD4 counts and advanced HIV. This is the CT scan appearance of an individual with brain abscess related to toxoplasmosis. And here's the appearance of the back of an individual's eye who was suffering from cytomegalovirus retinitis-related visual loss. And you can see this extensive area of bleeding and exudate where the whiteness is. And this is not something that recovers. It ends up resulting in a scar and permanent visual loss. Unfortunately, so many of these patients became blind. And this is an example of the sort of desperation to try to treat cytomegalovirus infection. It's a diagram of the eye, and you can see the cornea of the lens, and then the surgically implanted sustained release ganciclovir, which was something that was trialed after a number of years of managing patients with CMV retinitis when oral or intravenous forms of ganciclovir were difficult to achieve adequate concentrations of the drug within the eye, resulting in this sort of an intervention, which was really unique, and thankfully patients aren't in the situation where this is needed anymore. Other patients with severe lung involvement may end up in the intensive care unit with respiratory failure. This is Pneumocystis pneumonia. And others with intestinal or widespread infections such as bloodstream infection from Mycobacterium avium, also referred to as MAC, would suffer tremendous weight loss and often would not recover their weight and would have a downhill course. This is the appearance of Kaposi's sarcoma skin lesions related to human herpes virus 8. And you can see that these can be cosmetically hugely problematic and very disturbing for individuals affected. So the impact in the pre-heart era was huge, and once an individual was identified as meeting an AIDS diagnosis, the survival was usually in terms of months or a year or two. The early period in the early 1990s, our AIDS care group at St. Paul's, which was made up of about 25 or 30 individuals, multidisciplinary team involving nursing, social work, physicians, and so on, met on a weekly basis, and typically we were seeing one death per day at St. Paul's Hospital. Although this hospital treated the majority of the patients provincially, it's still just one hospital. So one can imagine with an individual being given a new diagnosis of HIV in those days, not only was it a death sentence, but it came with stigma. And the stigma was motivated by either judgmental behavior or other individuals' fear of contagion, or both. These people were frequently shunned in their community and also by some healthcare providers. And the revelation of a new diagnosis of HIV for many individuals who had not come out with respect to their sexuality represented an overwhelming emotional stress in terms of having to tell their family or friends that they were both now HIV infected and that their risk factor was that they were gay or that they'd had substance use with injection drugs. A lot was written about this, not surprisingly. This was an article that came out in Maclean's raising really the awareness around ostracization, which was a huge problem. In terms of trying to capture the mood of the hospital and the community situation in the very early days, in the early 80s, when these patients were first being stricken with the disease, I thought that this caption from the Providence Healthcare Archives museum document, which is online, and I would recommend anyone who's interested to have a look at it. There's a quote from Irene Goldstone, who was one of the nursing leaders and was with the center a number of years ago. She was an academic and very much involved in clinical practice and education. And her take on the early years was the first AIDS patients were our own staff. This hospital lost so many people, I stopped counting at 45 to 50. The impact on our staff was devastating, and it just kept coming. We'd come in and say, who's sick now? These people were not becoming infected in the workplace. This was really the gay community. We have many gay medical staff members and staff members throughout the hospital through that time, and they were often coming in as some of the earliest patients. This just shows some of the March activity of the ACT UP group that was most prominent in New York and elsewhere in the US, and then branched out and extended to numerous other countries. Advocacy also not just came from the affected risk group, particularly the gay community, who really showed activism in a way that was unprecedented, and they were so effective in bringing about change in various aspects of healthcare related to this, ranging from the FDA to doctor-patient relationship, and we'll come back to that later on. But this was an example after the introduction of heart therapy in 1996 of advocacy about a decade later when some of the patients with multi-resistant, drug-resistant HIV were starting to fail therapy, but there were investigational drugs that were still being developed. But after a struggle with Health Canada, Dr. Julio Montana was able to secure investigational therapy for a number of individuals who had run out of options and were approaching a fatal outcome. And one of these included a well-known Vancouver artist, Tico Kerr. And this was a widely publicized triumph in advocacy at that time. And in response to that, he painted the painting showing the old portion of St. Paul's Hospital, the Burrard building shown here. And he's alive and well many years later, as are the others who benefited from such advocacy. So this is the last full demonstration of the AIDS Memorial Quilt. It started in San Francisco and grew from there. It was displayed a number of times, but in 1996, this is in the mall in Washington, near the Washington Monument. And this quilt was a memorial, and it's important to remember that many patients with AIDS didn't get a funeral because of family concerns related to stigma or funeral homes and cemeteries that would not be involved. This represented 94,000 names. Each panel was 3 feet by 6 feet, representing the approximate size of a casket, and altogether weighed 54 tons. It's currently stored in San Francisco. It was moved around from place to place. This just represents the impact that was absolutely overwhelming at that time. Then in 1995, we started to notice a few things that were different. After 13 years of this very dark time, we became quite familiar with a variety of opportunistic infections that we'd previously rarely or never seen before 1982, 81. But a couple of things stood out. One was that these opportunistic infections weren't behaving in the same way as usual, and it became evident that this was associated with rapid rises in CD4 counts and suppression of viral load in individuals who were enrolled in multi-drug combination antiretroviral clinical trials, which were not yet presented or published. And also surprising recoveries in individuals who we expected to be terminally ill. One example on the AIDS ward was that a 35-year-old man came back to the ward 6 to 8 months after being discharged, and he was doing very well. And he came up to the nurse who was previously the main caregiver during his 4-week hospitalization on the ward, and he was thanking her for her help. And after a few minutes, she said, "I think you've got the wrong nurse, because I don't remember meeting you in the past." And he had to show a picture of himself when he was sick because he'd gained 50 pounds and was unrecognizable. So these were the sort of things that were showing up, making people wonder, okay, what's happening? This is an example of one of these immune reconstitution inflammatory syndromes showing multiple abscesses on a CT scan of the neck, something that was not really typical for advanced HIV disease-related MAC infection. It's just not a feature of it. But it became evident that these infections were now being modified by a brisk immune response related to antiretroviral therapy. So in 1995, although there was some glimmer of hope, was there really a light at the end of this very dark tunnel? 1 year later, at the Vancouver International AIDS Conference, it became clear the answer was there was a light. And Dr. Montana presented the results of the INCUS trial along with others, and it became evident at that point that triple drug antiretroviral therapy was changing the course of HIV disease in a dramatic way. And thankfully, we've never looked back.
Well, thank you so much, Peter. I was just listening to you, brought back so many memories for me too, and I'm hoping that I won't cry, but I already am. Okay, so let's just kind of think back a little bit. It's hard, it's gonna be hard to choose, but what would you say would be one of the more memorable experiences you had treating AIDS at St. Paul's back in the day, back in the early days of the pandemic, say, back in the sort of early to mid 80s?
Well, I think that one of the first notable things was the overwhelming nature of the problems that these individuals were confronted with. Such a variety of problems, many of which were, if not disabling, some of them were just devastating, and it changed the lives of these individuals dramatically. The treatments for opportunistic infections and cancers are there. They've certainly been improved greatly over the past 30 years, but they're only moderately effective, and unfortunately, it was really a downhill progressive decline for so many of these people. So it was distressing, to say the least.
Yeah, I remember we just couldn't focus on just one problem. It became, for me, it was one of the things that I found so captivating about treating HIV, is that it wasn't a single system disease. We weren't, not to disparage anyone, but we weren't focusing on just one system. When you thought you sort of knew what was happening with the pneumonia, then the patient would say, oh, and by the way, I have kind of a horrible headache today. And then you're sort of starting all over again, looking for new problems and trying to figure out what was going on. It was all encompassing.
Oh, exactly. And this is a disease that did not just involve general practitioners, internists, and infectious diseases physicians, but also ophthalmologists, gastroenterologists, numerous intestinal infections, respirologists who would investigate these patients and do bronchoscopies to try to provide an answer as to whether or not pneumocystis was the problem, or was it tuberculosis or something else. Neurosurgeons, neurologists, all sorts of problems would develop. And
then we were treating not only the entire patient, but also all the social issues that you sort of alluded to in your presentation too, where they were not able to work anymore, and who was supporting them, and then the friends and family that were shocked and worried, and there were all those sorts of issues too that were part of the whole care plan. And I think that's why we were so fortunate to have the care teams that then eventually evolved. But to that point, what do you think that, you mentioned this too, but the stigmatization for people living with HIV in the 80s was overwhelming, right? And what's your memory around that?
Exactly that. I think that we're in a better place today, certainly than we were 30, 40 years ago, with respect to acceptance of sexuality when it's not just heterosexual activity. So we're not, we've got a long way to go yet, but it was much darker in those days, and all this came out in a way that made it so much more difficult for individuals. I remember one example when I was in the medical short stay unit, where we frequently treated patients with HIV who had CMV disease, particularly CMV retinitis, and were on long-term intravenous infusions with ganciclovir. A lady was admitted there for an angiogram. She was HIV negative, but when she found out that the person in the next bed to her was HIV positive, she signed herself out, canceled the angiogram, and left. Very sad. And that was well after 1983, when it became clear, or it was known, but still in the general population, there was this fear, whether she left because of the stigma or because of fear of contagion, hard to know. But that's what we were dealing with, what the patients were dealing with. One of the most disturbing examples of that was covered in the media came from Florida, and this was an instance where a family of number of boys, 3 of them had hemophilia and were all HIV positive as a result of their treatment for hemophilia, were banned from their local school by the school board. And it took a federal judge in the US to make a decision and order the schools to re-enter them back into the school system, which happened, and there was outrage from the other parents, and within a few weeks their house was burnt to the ground. So that's the level of fear, stigma that was out there at the time.
Yeah. We have a listener that's joined in already saying, as a patient, he wonders whether we also experience stigma as care providers that chose this field, or at least, ended up in this field, looking after patients who were HIV positive. Do you remember that as an issue at all?
I'm sure there may have been situations where that happened. I can't say that I experienced that myself, but others may have.
Yeah. It was a really upsetting time, that's for sure. There's another comment here saying from Dr. Giammi. I hope she doesn't mind that I bring her name in, but she's also been so involved in our team and has spent decades working with us. And she was saying she remembers doing her CTU rotation here, the clinical teaching unit rotation here at St. Paul's, and lots of the beds were occupied with patients who had AIDS and HIV, and you were the one, see, this is gonna make me cry too, you were the one to listen and to learn from. Yep, sorry Sylvia, I don't know if I can go through this all, but dedication and compassion to your patients was amazing. And you were an example for us all. So, goodness, I didn't know that this was going to be so upsetting for me. But how did the patients cope, given all their significant disabilities related to their medical complications? Like, what do you remember about how they were able to deal with their issues?
Well, while they were in hospital, the teams, I think, did a great job. The nursing staff was hugely supportive, and there was just a very open door, welcoming attitude in the hospital that really started from the top. Sisters of Providence, the nuns, were completely on board with fully embracing the HIV population from day one, which was not the case necessarily elsewhere. And so that sort of spirit made a big difference. And the head of the Department of Medicine, John Rudy at the time, also was a very important leader in that regard. And as a result, the JRC, the John Rudy Clinic, is named after him. So there was a very positive attitude in the hospital. But once they went home or went out elsewhere, then what? And that's where the tremendous growth just sprung out of nowhere. Well, it didn't sprung out of nowhere. It sprung out of the community. This was really grassroots movements across the country and around the world that provided supportive care in the way of counseling, assistance in any aspect of their lives, emotional and otherwise. Organizations such as AIDS Vancouver, they relied on a lot of volunteers, but these organizations were instrumental in helping people in this very dark time. And those organizations really played a huge role.
Yeah, I agree. So much support from family and friends and community that just really made such a difference in the whole management of symptoms and disease. A few more comments in the chat box, but I do want to ask, let's talk a little bit more about the frontline experience of treating people with HIV and AIDS back in the 80s and 90s. Like, what do you remember specifically medically? I'm not going to cry anymore. That's enough. Yeah. Okay.
Well, the inpatient side was organized where the majority of patients were hospitalized on general medical units with consultation to one or another of the most relevant specialists, whether it was a lung infection, a respirologist would be involved, and so on. At any one time, there might be up to a few patients hospitalized in the intensive care unit, and then in medical short stay, there were various reasons for people to be followed there, but CMV disease, particularly retinitis or gastrointestinal disease, were the main reasons for ongoing intravenous infusions, although there are other intravenous treatments that were also administered from that location. So those were the main locations. We had the AIDS care team, as I mentioned, about 25, 30 people. We'd meet once a week and review management and discharge planning arrangements on a regular basis. And there was a sort of a camaraderie that developed, a team spirit around the management that really helped through the years. We would sort of cover off for each other, help out whichever way we could, and the sort of sense of sort of a team fight against a common foe. The AIDS care team was led by Dr. Alistair MacLeod, who's a dermatologist with an interest in Kaposi's sarcoma, and a long list of others who I can't really, I'm not going to try to name them all, although there were also a number of family doctors in that group who are still in practice at Spectrum Health Clinic just a few blocks away. So it was a very collegial group and it helped a great deal. And then a number of years after the epidemic began in Vancouver, the AIDS ward was opened up on the 10th floor on 10C, which was initially a 12-bed unit, but soon expanded to become a 20-bed HIV positive unit. And that was very helpful in allowing us to have these individuals managed under one roof. There were many advantages to a geographically based unit, particularly in terms of recruiting staff. People wouldn't go and work there if they had prejudices and stigma and so on. So we had a head start in terms of staffing just by having them all in one location. That was a big plus. The unit was adjacent to the palliative care unit on 10 Delta, which reflected the very poor outcome at the time when the ward opened, given that many of our patients were transferred to the palliative care unit. And it was gratifying to see after '96 that we didn't need to be co-located with palliative care because the mortality dropped dramatically.
Yeah, you're right. The AIDS care team, having the HIV unit, they just helped us, first of all, just develop that amazing multidisciplinary care that I think that many other specialties or sort of, specialty disease groups are also modeling their care after now, like in oncology and things like that. I think, we had the advantage of having so many people there that brought so many different strengths to the fight. So true. And then it also helped just having all the care centralized to see sort of patterns of disease and, this is happening again, this is happening again, like you were saying with immune reconstitution, I saw that, I saw that too, that's happened with my patient, and all of a sudden we realized it was something, right? Really, really powerful. I remember the 80s and 90s, I remember that HIV, like what is HIV, was a bonus question on one of my biology exams in my undergrad degree. And then I remember in the 90s being your resident and fellow, no crying, and and those long days. And for some reason, what I remember is being on call with you and seeing patients and looking after people in the hospital, and then going over to the clinic because our secretary in the clinic would be calling saying, well, now there's urgent things to do in the outpatient clinic, so you have to come back. And it was 5 o'clock, 6 o'clock. And I remember crossing over from the main part of the hospital to where the clinic was. And for some reason, it was always dark and raining in my memory, so I don't know what that means. but how dedicated she was too. I just didn't want to go through this without not mentioning her. And I don't know, I didn't talk to her, so I didn't want to bring up her name, but she was, supporting you and Dr. Montana and all the other physicians that were working in that group. She was amazing. Never ever once complained, never ever once said, I want to go home. Yeah, amazing. And really was, so much of the care involved providing emotional support and social support too. And she was, the whole team was really amazing at all that.
The HIV ward went on for many years, and then when it was close to 20 years since it was initiated, it was renamed, and because of the declining inpatient census of individuals who were HIV infected, the admission criteria were modified, although the unit is now referred to as urban health. That's where the majority of HIV positive individuals are cared for. But during the early 90s, in the pre-HAART era, at any one time there were 25 to 35 hospitalized patients who were positive, and that number only gradually declined, because even after the mid-90s and the initiation and introduction of triple antiretroviral therapy, the epidemic also began to increasingly involve the injection drug use community.
Yeah, and that was a hard community to access and care for, although now obviously we have so many care providers that are doing that successfully, but that was initially really a big challenge. I remember that. Not that I want to dwell on this for too long, and we've talked about the camaraderie and the teamwork that went into the care that was provided in that time. But how else do you think treating the AIDS patients really did affect the healthcare providers? I mean, there were certainly a lot of successes and a lot of good that came out of it, but some of it was difficult.
For sure. I think the emotional toll of this is, it's variable from one area of medicine to another. And I think that although advanced HIV disease in the pre-HAART era is certainly a difficult one, I think that the commonality is particularly disturbing for healthcare providers is when the diseases being treated are associated with relatively high mortality, when they affect people who are relatively young, and when the timeline from diagnosis to death is measured in months or a few years, providers end up with an opportunity to really get to know the patients. Mm-hmm. And so when you lose them, it's difficult. I remember being invited to the funeral of one of the first HIV positive individuals that I was involved in treatment back in the 1980s. And the funeral was a very moving experience, but after that I realized that I can't do this. I can't be going to funerals on a regular basis and stay in this work. And that was the first and last funeral that I went to. It's just too much. And I think that when you have situations where people have multiple conditions and factors that may influence their survival time, and numerous decisions end up being made diagnostically, therapeutically, and so on, it's very easy after the fact to start to second guess one's decisions. If we'd done this or that a week or two before, would that have perhaps changed the outcome to a certain extent? Would that person have survived a bit longer? It's just very difficult to avoid that sort of a thought process, and it doesn't get any easier over time. That's something that stays with you.
You know, it's amazing what makes it come back. You know, I was thinking about this session and realized that even to this day, there's a certain brand of lip balm that if I see it in the grocery store, it reminds me of a patient who would use it because he had dry lips from the oxygen from the PCP. So yeah, those things, they don't go. It's hard. So
and people often don't want to talk about it because it's painful.
Yeah, it's really painful. Yeah. So let's talk about those people who did survive, because there were some. And, we still do follow some people living with HIV who came from the pre-heart era. You know, what sort of observations have you made about those? Are there things that they still live with that have to do with what they went through? And what are your memories around that, or your thoughts around that?
Well, the majority of those patients have moved on, and they're only followed by their family doctor because they no longer have problems with opportunistic infections, and I'm an opportunistic infection doctor. So I don't retain so many people in my practice for those reasons, but I do have people who I follow with HIV and who still have some residual, perhaps an area of reduced vision in one eye related to CMV retinitis in the pre-heart era, and they've survived for years and years since then. So that occurs for sure. One of the other interesting things about the people who were affected by HIV in those few years before heart triple therapy became available in 95, 96 is that because it was well recognized as a death sentence, people cashed out their insurance policies. Insurance companies would recognize that, and it was very gratifying to see people who had done that a year or two later coming in and actually mentioning, well, I didn't need to do that. And they've spent their life insurance, but the good news was that they managed to squeak through. So those were interesting times and when that transition happened.
Mm-hmm. I remember they'd go back to school, they'd go back to work, after having stopped going to university or whatever. Then they'd come back to the office a year later and say, oh, how are you doing, whatever, and oh, I'm back at work, I'm back at school. Okay, great.
That's right.
Yeah.
So many of them would automatically retire as soon as they got the diagnosis.
Yeah, so they completely went back to their, well, they tried anyways. I mean, there was certainly a component of survivor guilt. I think I kept some of those patients because I did look after them still for their antiretroviral care and things like that, and certainly there was some pretty significant survivor guilt. And I think now we talk a lot more about mental health, but at that time, I don't think we really realized how much that was a part of what they were going through as well. So that certainly has changed too. Couple more questions in the chat, and I'm kind of just watching the time too, because I feel like we could stay here forever. So, okay, this one's a bit of a curveball. Are you ready? So what lessons did you learn from the challenges and frustrations with treating with the early patients? Do you think you can extrapolate any of them to current and future pandemics? We couldn't go through this without talking about COVID.
Well, yeah, for sure, we've learned a long list of things from COVID. With the HIV pandemic, I think that the lessons there have been more just a matter of looking to see how people can cope with these problems in the face of tremendous adversity, and how society pulled together in so many ways to try to reduce the pain and suffering that occurred. But I think that one of the main things is the importance and the need to keep the impetus up with respect to clinical trials and research to develop new antimicrobials that may be able to make a difference. And the investigators who were doing the research in this area had spent really 13 years with really frustrating outcomes. The results with monotherapy, AZT therapy, or even two-drug antiretroviral combination therapy were not all that helpful in reducing the mortality. And it was one study after another with disappointing results, and the mood was low. And then finally, the third drug added to the combination made the difference. And so it's just the relentless sort of perseverance of the research community who have pushed ahead in the face of frustrating results. Really, that's it's such a tribute, and really an example for how to continue to try to fight these things going forward. The success that we've had with COVID in the way of diagnostics and treatment and vaccination advances are really staggering. HIV, much more difficult, but still.
Mm-hmm. Yeah, I think that's you bring up a good point, just how our medical knowledge advanced so quickly, and at the same time the lab knowledge advanced really quickly. I mean, what factors do you think were the most important in bringing about BC's success in controlling the HIV epidemic?
Well, I think unquestionably the triple drug therapy was the turning point, and that made the big difference, as was outlined in the mortality curve. But there are numerous other things that have been generated by the BC Centre under Dr. Montana's direction, not just the combination heart therapy successes, but also the establishment of the BC Centre for Excellence in 1992, which provided a tremendous environment for growth and progress with respect to HIV disease, not just in terms of treatment. The drug treatment program has been really a global example of an outstanding delivery care model and management program for antiretroviral therapy, which is provided free of charge in the province.
We say that really such drastic changes over really just a relatively short period of time. I mean, there were millions of deaths, but then millions more lives have been saved since then, and it really was nothing short of miraculous, I think, what could be accomplished here. So I'm so sorry that we are running out of time, because there are so many more interesting comments and questions that have come up. But at this point, I think we're going to have to just bring this chapter of our discussion to an end. And I can't thank you enough, Dr. Phillips, for discussing your experiences in the 80s and 90s, and for the commitment you made throughout your career to this, to the care of people with HIV and AIDS. If there are any additional comments or feedback from the audience, we would love to hear it. Please send us your emails at bc-cfe.ca. Additional comments in the chat, we'll try to get to them and hopefully be in touch with you at some future point. And once again, thank you for attending. This series of lectures is going to continue, or series of sessions is going to continue, and we look forward to you joining us for the next chapter of our conversation series towards the end of June. So once again, thank you all for joining us. Thank you, Dr. Phillips, and we look forward to you joining us again.